Hi, I'm Andrew Curley from the American Hip Institute. Today I'll be talking about a study that I performed while I was at the University of Pittsburgh Medical Center last year with Dr. Michael McClincy. The title of this study is Does Pelvic Tilt Change After Periacetabular Osteotomy for Hip Dysplasia? Disclosures are up on the AOS website. So spinal pelvic alignment over the past couple of years has garnered increased attention, especially in the field of hip preservation. Several of the common measurements that we use to evaluate spinal pelvic alignment include pelvic incidence, which is considered to be a static measurement, as well as pelvic tilt, which is a dynamic measurement that can change from one time point to another in the same patient. When we evaluate pelvic tilt, a lot of the prior studies in the literature come from the field of hip arthroplasty as demonstrated in this image, but the same concepts oftentimes hold true for patients with non-arthritic hip disorders. So if you take a patient with normal pelvic tilt and you decrease their pelvic tilt, it looks more like an inlet X-ray versus increased pelvic tilt looks more like an outlet X-ray. Patients with decreased pelvic tilt have increased superior lateral coverage of their acetabulum and also create an environment of relative acetabular retroversion. In contrast, patients with increased pelvic tilt result in decreased superior lateral coverage of the acetabulum and created an environment of relative acetabular aneversion. In other words, a more unstable hip. One of the questions that's come up in the hip preservation literature is for patients with hip dysplasia, is this decreased pelvic tilt that we sometimes see an adaptive change? In other words, are patients decreasing their pelvic tilt to give them more superior lateral coverage and symptomatic relief? And if so, does this adaptive change go back to its native alignment after PAO surgery to increase their superior lateral coverage? Several prior studies in the literature have attempted to answer this question. Daly et al. In 2019 noted that there is a modest change in pelvic tilt in patients that underwent bilateral periacetabular osteotomy. In contrast, of note, this study used the PSSI index, which can be prone to error due to anatomic variations between patients. In contrast, two subsequent studies noticed no significant change in pelvic tilt. However, these studies use supine radiographs rather than standing radiographs to assess pelvic tilt, and it's been well established in the literature that spinal pelvic parameters change from the supine to standing position. Additionally, these studies use the SFP angle as a metric to determine pelvic tilt. This SFP metric that they use was initially defined in the spine literature by Blundell et al. In 2012. And this study used this angle to determine pelvic tilt. This angle was defined by a line from the top of the pubic symphysis to the center of the femoral head, to the top of the sacrum, which creates the SFP angle. The pelvic tilt is then calculated from this formula, which has been subsequently studied in further studies and been validated to be accurate. So the purpose of our study was to address some of the prior limitations in the hip preservation literature and determine if pelvic tilt changes following a unilateral or bilateral PAO. Our hypothesis is that there would be an increase in pelvic tilt or relative acetabular aneversion observed postoperatively. This was a retrospective review of PAOs performed by a single surgeon over a 3-year period. The surgeon's typical X-ray protocol involved preoperative, postoperative X-rays at the roughly 7-week, 6-month, and 12-month postoperative time points. And notably, these were standing X-rays rather than supine X-rays. At each of these time points, the SFP angle was assessed, and if there was missing data or X-rays at that time point, then the patient was excluded from analysis at that time point. So of the 47 patients that were eligible for inclusion, 5 patients were excluded due to inadequate imaging, leaving 32 unilateral PAO patients and 10 bilateral PAO patients. These are the demographics of the two groups, which were comparable. Notably, the preoperative lateral center edge angles were about 15 to 17 degrees for both groups, and the postoperative lateral center edge angles were corrected to roughly 30 to 31 degrees. So at the first postoperative visit, around 7 weeks after surgery, there was a wide assortment of changes in pelvic tilt from decreased to increased pelvic tilt, as demonstrated here for both groups. However, things got a little bit more interesting around the 6-month postoperative mark particularly in the bilateral PAO group. As seen here, there is a general shift towards increased pelvic tilt in the bilateral group, which was also sustained at the 12-month postoperative mark. This line graph is another graph demonstrating the same findings, and you can see the bilateral group with the gray line above, with an increased pelvic tilt from preoperative to 7 week, 6 month, and 12-month postoperative of about 2 to 3 degrees. Notably, at the 6 month and 12-month mark, this is a statistically significant finding. This is a case example demonstrating this finding. This is a young female who underwent bilateral PAO surgery. Preoperatively, her pelvic tilt was 9 degrees. Postoperatively, at 6 months, her pelvic tilt had changed to 14 degrees, and this was sustained at a 1-year time point as well. So this supports the theory that the patient may have been decreasing her pelvic tilt preoperatively to give her increased superior lateral coverage, and then postoperatively, after she had a PAO and had more superior lateral coverage, her pelvic tilt could relax back to its more native alignment. This supports the theory that spinal pelvic alignment may be a dynamic process adapting to changes in femoral head coverage. And it suggests that stage bilateral PAO patients demonstrate an increased pelvic tilt starting around 6 months postoperatively. So why do we care about pelvic tilt? Well, the implications of these findings could be applied during our planned PAO corrections. For example, if we know that there's a subset of patients that will have a change in pelvic tilt at a certain time point postoperatively, then perhaps we will adjust them more or less during our PAO surgery and give them more or less acetabular coverage. Furthermore, if patients have maladaptive changes in their pelvic tilt, then they may respond to targeted physiotherapy to address these changes. Finally, if patients are changing their spinal pelvic alignment and putting more loads through their lumbar spine, then the PAO may affect the natural history of spine pathology that these patients would develop years later. Limitations of this study include that it's a retrospective review. There's a small sample size, particularly in the bilateral group, with 10 patients at the first postoperative mark and 8 patients at the 1-year mark. And SFP angle is an indirect measure of pelvic tilt. These patients did not undergo lateral lumbar spine x-rays to directly measure pelvic tilt. The conclusions from this study is that in our cohort, bilateral PAO patients demonstrated an average increase in pelvic tilt of 3 degrees as assessed by SFP angle at 6 months and 12 months postoperatively. And it suggests a compensatory adaptation after surgery with implications in rehabilitation regimens and planned surgical corrections. I'd like to thank Dr. Michael McClincy and the University of Pittsburgh Medical System for their help with this study and their mentorship. Thank you.